Okay, with furthermore, no more delays, let's go to our seating and mobility presentation. Okay. Already they gave introduction about me, so I no need to explain furthermore about me. Let's begin our webinar. Okay, what is our agenda for today? We are going to see what is introduction, and we are going to see what is wheelchair, and seating team members, and OT role, and we are going to see what is a brief history about seating and mobility in Kuwait, how it developed, and we are going to see the process of seating service, and we move on to facts about sitting posture, and then we move on to symmetrical posture and benefits, and we are going to see in detail about the wheelchair components, and we are going to see the types of wheelchair, and finally we are going to see seating and assessment with the case scenarios and with the live videos. I'm sorry, not live videos, recorded videos, and how can we select an appropriate wheelchair, and finally take home messages. This is our agenda. It's going to be. It's going. I would like to have an interactive sessions with you. So please, if you have any questions, please post it in the chat box so that Mrs. Rima will communicate with me. Okay. Am I audible?
Yes, sir, you are audible.
All right. All right. Thank you. Okay. Let's start about the introduction. Okay. The wheelchair is viewed as one of the most important assistive technology devices used in the rehabilitation. For the individuals who cannot ambulate or they have a difficulty in ambulation. Okay. The WHO recently have the statistics that 70 million people around the world have wheelchairs they needed, but only 5 to 3% they haven't access to it. The numbers are huge. The difference is also huge. In addition to that, there is a shortage of the rehabilitation person, those who have a knowledge and skills to provide the wheelchair that meets the user specific needs. So this is huge in number, and being an OTs, okay, we supposed to get an awareness about the seating and mobility to serve or to meet this much of population in the near future. Okay. What is wheelchair? Can I have a few answers for this? What is wheelchair from your perspective? The participants, maybe can I have a few answers for this? You know, how do you understand wheelchair from your perspective? Mrs. Rima, can you coordinate with me if you get an answer, please?
Yes, sir, I'll read it out if I see answers.
Yes, yes.
Seated mobility.
Okay.
Seating device for disability.
All right. All right. Good. Thank you so much, those who are participated in that. Okay, what is wheelchair? This definition I like more. Okay, I think few more is coming, but still we'll move on.
Yeah.
Okay, a wheelchair is an assistive device which is manually operated or power-driven device designed primarily for use by an individual with mobility disability. This is important, mobility disability, for the main purpose of indoor or both indoor and outdoor locomotion. There are many definitions you will find out if you go to Google, or there are books available, but I like this definition more, and this is given by American Disability Association. So this is an appropriate definition for what is a wheelchair from my perspective. Okay. Next is, what is specialized wheelchair? If you know what is wheelchair, if you know what is the definition of wheelchair, then we're supposed to know what is specialized wheelchair. This is how the webinar is for today. What is specialized wheelchair? Okay. Specialized wheelchair seating is a term, okay, that describes a number of postural components or postural accessories, okay, which are specially designed to be used in a wheelchair base. 2, provide optimize the disabled person's abilities or skills to better perform in their own environment. So this is what the specialized wheelchair is all about. Okay. Now, let's move on to seating team members. So this is an multidisciplinary team, okay, headed by the physiatrist, okay, and then OT, PT, rehabilitation team engineer, nurses, social worker, family members, all we work in collaboration to meet the need of the client, okay. So in this multidisciplinary team approach, everybody supposed to know their roles clearly. There should not be any role confusion. If there is role confusion, then there will be an issues. Okay. All right. So what is OT role in seating and mobility? Okay. We are unique profession in seating and mobility. Why? Because OT are the only healthcare professionals who use PEO model, which is person, environment, occupation model. So being an OT, we know what is PEO model. Okay, that the person domain includes like roles, self-concept, the cultural background, personality, cognition, physical performance, the sensory capabilities. All those things comes under person domain. If you take environment, the domains includes physical environment, and then cultural environment, social environment, socioeconomic environment. All those things comes under environment domain. The occupation domain, if you take, it includes a group of tasks that the person engages in daily activities. So we assess based on this model, okay, and we are recommending wheelchair equipment. When we do this, we become unique. I don't think any other profession really does this based on the PEO model. So we are unique in terms of seating and mobility. Not only this PEO model, we provide in-depth knowledge about occupational performance and participation. This brings a distinct perspective on the impact of habits, roles, and routines of the life of the individual. That what piece of an equipment will really better suit for him in different types of environments using a client-centered approach. Okay, so if you know this role clearly, there will not be any role confusions. There will not be any issues when you are dealing with a multidisciplinary team. All right. I'll just go through a brief history of seating and mobility clinic in Kuwait. Okay. The idea started in 1997 that OT department in physical medicine and rehabilitation hospital, they took a leading role in development of seating services in Kuwait in 1997. The seating clinic was established here in Kuwait by Canadian occupational therapy team headed by Margot Russell and along with Dr. Amal Al-Maghrabi. She was the head of the department since many years, and she recently resigned in 2018. And she was my mentor in seating and mobility. I really owe her a lot. And this team, Canadian team and Dr. Amal Al-Maghrabi, they took a responsibility to develop a comprehensive structure, policies, and proposal to start a new service in 1998. So I joined the seating clinic since 2007, and I'm working until now there. Now, let's go to process of seating services. If you want to develop and establish any new services, you need to have a well-defined plan and well-defined policies. Okay. Okay. Why do we need a well-defined policies or guidelines? We can say that. Okay. Okay. Here comes with the points to discuss. The well-defined policies or guidelines, it provides it's a framework, okay, to identify the essential needs or the steps, okay, to get the wheelchair. It provides guidance regarding how to secure a fund, not only for the person, and how about for the stakeholders, and how about for the suppliers as well. If you have a well-defined guidelines, it improves the clinical care and ongoing support to the disabled population. And once you have a policies, it stimulates further research in this area in order to provide the evidence-based practice. And if you want to expand the services furthermore, you can do that if you have a well-defined policies. These policies not only helping the disabled population, it also helps the family and the caretaker of the particular disabled person. By saying all those things, seating and mobility clinic in my department, we have a well-defined policies. Okay, here comes the important steps. Okay, it starts with the referral. We have a well-defined referral policies. Okay, so once you receive the referral, we set an appointment for an assessment. Our assessment is very comprehensive assessment. I will discuss about how to do assessment in my future slides. So after you do assessment, okay, we make a report. Once you make a report about the types of wheelchair and what are all the accessories required and everything, we send it to the approved companies. Once the approved companies receive our reports, they will read it, and based on our report, they will develop a quotation. Okay, it can be one company, it can be two company, it can be more than that. It's all the based on the need of the patient. So once the company, they prepare the quotations, they will send back to us. Once we receive the quotations, okay, we go through the quotations and we will match with our report. Is it matching the quotations? Once everything is done, we will set an appointment for a trial. So during a trial, the company, they will bring the demo chairs. So we will make the patient sit in the demo chairs, and we will see all the recommendations from us. Okay, is it really fit for the needs? The advantage of doing a trial is if you want to change anything, or if you want to add anything, or if you want to remove anything, everything is possible during the time of trial before you go for an actual purchase. So once your trial is finished, you document your trials and you submit all the documented papers to the funding resources. These funding resources can be, it's different from the country to country and depends on their environment. I don't know how the procedures, it's all different from one place to another place. So once we prepare the trial papers and trial documents to the funding resources, then the funding resources, everything will be done and they will send it to the company. And the company, they will purchase the wheelchair. And once they purchase the wheelchair, and they will contact us, okay, the wheelchair is ready for the patient. Then again, we will set an appointment for the delivery. So during a time of delivery, we again go through our trial reports and we will just match with our specifications, and we make the patient sit on the wheelchair and we teach them how to in and out of the wheelchair, how to take care of the wheelchair and everything, and we will document the process. And the next step is for follow-up. The follow-up procedure is mandatory for pediatrics. We used to give follow-up appointment every 6 months to meet the child's growth. And for adult, the follow-up is as required by the patients. So once our follow-up is done, the next step is a reassessment. The whole procedures, starting from referral to reassessment, we have a beautiful, well-defined documentation procedures. So all these data are documented for the near future. Okay. All right, this is our steps in seating clinic. Okay, all right. What are all the evidences available worldwide? Is there any other guidelines we can serve? Yes, definitely. The WHO has given 8 steps guidelines for wheelchair service provision. Let's see what are all the 8 steps guidelines. The guidelines, again, they will start from referral, and then they move on to assessment, then prescription of a wheelchair, then funding and ordering, product preparation, fitting and adjustments, user training, follow-up, and maintenance. This is from WHO guidelines. Is there any other evidences? Yes, we have a RESNA. I don't know how many of you have heard about RESNA. Okay, RESNA is the Rehabilitation Engineering and Assistive Technology Society of North America. It is the premier professional organization. It is dedicated to promote the health and well-being of the people with disabilities. RESNA is a very well-known platform for the assistive technology. They provide a lot of certification programs, and they conduct a lot of continuing educations and professional development programs for assistive technology. and they promote a lot of researches. They have a lot of articles regarding seating and mobility, regarding assistive technologies. They have I strongly recommend this. Those who are not having any awareness about RESNA, please go to the website, and loads of informations are available about assistive technology. I'm really impressed with this RESNA. And once you have, if you want to read about furthermore about seating and mobility, there are beautiful articles are available in RESNA. Now, what RESNA says, RESNA guidelines. Okay, we have seen our guidelines and we have seen WHO guidelines. Now we'll go to RESNA guidelines for the seating and mobility process. They also start with the referral, and referral moves to qualified professionals like OTs, and they do assessment. In RESNA, the assessment is done based on 3 domains of ICF, International Classification of Functioning. So they assess based on 3 domains, which is body structure and functions, activities and participation, environment, and current technology. Then they move on to equipment recommendation. Then they do equipment trial, then funding and procurement, then product preparation, then fitting, training, and delivery, then follow-up and maintenance, finally documentation. So we have three guidelines or 3 policies, well-defined policies. If you look at this, the steps involved in all 3 is almost all the same. Maybe the implementation of this process may be different from country to country. It depends on the health sector, depends upon the health insurance. Okay, but the essential steps involved, it's almost all similar. All right. Any questions regarding this so far? Please put your queries or in the chat box so that Mrs. Rima will communicate with me. Thank you. Now, let's move on to facts about sitting posture. How do we sit? We have many participants now. We are attending this webinar. Everyone is sitting now, maybe in a chair or in a sofa. Okay, and how do we sit? We have in mind about ideal sitting position, if not for us, for the patient. Okay, what is ideal sitting posture? Is it easy to take up this ideal sitting posture or pose? Well, some people can say yes. Some therapists can say no. Some of them can say, well, I don't know. For example, if you say yes, let's move further. Is it easy to maintain this position for a longer period of time when you say this ideal sitting posture? Well, if you ask this question, mostly 100% we will say no. Is it easy to maintain this ideal sitting posture for a longer period of time among ourselves? I'll say no. Even including me, I'll say no. It is not possible. Why? Why do we say no for this? Why? Why? Because the anatomy of the human body is made for movement. The bones, the joints, the muscles, the tendon, the structure, all this enables us to move the body, not to sit. So anatomically speaking, our body is made for movement, not to sit. Okay. So this is the reason why we say ideal sitting posture for a longer period of time. It is really going to be a $1 million question. Let's be aware of the various current sitting positions. We are all sitting now and listening this webinar. Are we all sitting in the same posture like each other? No way. It's not going to happen. If I say that you should remain in your current position right now, okay, fine, no problem. But how long? If I say that don't change your position for another 10 minutes, is it possible? Well, it's not possible. From my side, it's not possible. Why are we sitting in so many different postures? Why? What is happening? Why are we changing our postures frequently? Why does it happen? You have to think about in this perspective. And why do we change our when we changing our posture? Are we doing it consciously, or it is unconsciously happen? You have to get their answers. Okay, and if you are doing so, if you change your posture constantly, okay, why? What is our body constantly seeking for when we sit? Okay, please ask this question so that you will try to find out the answers. Okay, the answers we will go through it now, understanding the biomechanics from standing to sitting position. Okay, all right. If you look at our standing posture, okay, in a coronal view, look at the pelvic and the spine alignment. The pelvic is beautifully aligned, okay, and look at the spine, the anatomical curvature of the spine, which is cervical lordosis and mild thoracic kyphosis and mild lumbar lordosis. It's a beautifully aligned spine and beautifully aligned pelvic in standing position with this 0 degree of reflection. Now, let's move slowly to a sitting posture now. Let's have a hip flexion up to 60 degree. Okay, we are preparing ourselves to sit now. Let's say 60 degree of hip flexion. Just observe here the pelvic and the spine. Well, not much change between 0 degree and 60 degree. Still, the pelvic remains the same almost, and the spine also remains the same. Okay. The beauty is when you sit in this position, which is so-called 90-90-90 position, see the difference. What happened here? The pelvic tilted backward. Because the pelvic tilted backward, the spine, look at the spine, the lumbar lordosis is gone. There is no lumbar lordosis. Okay, so from standing, when it comes to sitting, okay, the pelvic is tilted backward, the spine is also goes to kyphotic posture. Well, if you look at the second picture, okay, can anyone give me the answer? When situation we you sit with a 60 degree of reflection? Is there any situation or where you will sit with the hip flexion with a 60 degree of maximum 60 degree of reflection? Can I get a few answers? Mrs. Rima, you can coordinate with me. 60 degree of hip flexion, where you will sit in your day-to-day life, or you have never sit in this posture. 90 degree, yes, maybe, and we used to stand, it's fine.
Vajrasan position.
Vajrasan position, okay, oh, good.
Riding bicycle.
Riding bicycle, okay, very good.
High sitting.
High sitting, very good, fantastic.
Squatting positions.
All right, with further no more delays, let's move now. I'll give you two examples now. This gentleman is now sitting in a chair. It's a low chair. Okay, he's sitting with 60 degree of reflection. Okay, look at his pelvic and spine. It is beautifully aligned. Okay, the pelvic is in neutral and the spine is having a nice lumbar lordosis and he's working on it. The beauty is there is no back support. Okay, and another scenario is when you are on top of the horse. Okay, if you look at the reflection, it is almost a 60 degree of reflection, and look at the spine of the person who is sitting on top of the horse. It is almost all, she is maintaining nice lumbar lordosis and the pelvic is still remains the same. Okay, so all problems happens when you sit with 90-90-90. All right, now, so what the tilted pelvis does to our posture? What happens when you sit in this position? Okay, all right, let's see one by one. When you sit in this tilted pelvic, which is posteriorly tilted, okay, what happens is the pelvic seeks the stability and constantly rotates backward. All right, because the pelvic tilted backward, the spine is on top of the pelvic, it also follows the pelvic. Because it follows the pelvic, okay, the lumbar lordosis is gone, it flattens. Okay, a chest kyphosis and lordosis also increases. This is what happens when you sit 90-90 position, okay, in our day-to-day life. Okay, why this is happening? Why can't I maintain an symmetrical pelvic in sitting? Why? If you look at this picture, beautiful skeleton of the pelvic, okay, can I get some answers in sitting? Which part of our pelvic is contact in surface? Any few answers, please. In sitting, which part of our pelvic is contacting with the surface?
Ischium.
Ischium.
Ischium. Ischium.
Ischium. Okay, all right, thank you. To be precise, in ischium, the ischial tuberosities are directly contacting with the surface. If you look at the beauty of this ischial tuberosity, these ischial tuberosities are, I'm sorry, the mic is on. There is a noises around me. I'm sorry for that. Yeah, thank you. If you look at the ischial tuberosities, they are very tiny bony prominence, okay? And if you imagine what is the distance between two ischial tuberosities, between right and left, you'll be amazed. This is just a 12 to 14 centimeter, which is very, very small between right and left ischial tuberosities. So on top of that, our whole body mass is built in terms of sitting, okay? So when you have this ischial tuberosity, the distance is very small, okay? You will have a weak lateral stability. That is the reason why the people will sit in this position. Okay, they will put their hands on the cheek, and maybe they'll put hands on the right hand over the cheek and left hand over the cheek. Maybe they will fold their hands. It all happens because of the weak lateral stability, because of the ischial tuberosity distances. Okay, now influence of the hamstring muscles. Well, this is really challenging because I'm working since many years with the patients with the hamstring problems, and it's really challenging. When you have hamstring tightness or contractures, it's really amazing to work with these people, those who are having an hamstring problems. Okay, all right. We will go to this part later. Let's see the anatomy of this hamstring muscles now. We all know that hamstring is biceps femoris, semitendinosus, and semimembranosus, origin, incision, everything. Okay, what happens in sitting? Okay, in standing doesn't have any issues with the hamstring. When we sit, the hamstring is on constant pressure. Because of the hamstring constant pressure, it pulls the pelvic backward. Because it pulls the pelvic, it goes backward, the spine follows, and all this asymmetry happens in the spine as well as in the pelvic. All right. So this is the second reason. The first reason is the distance between the ischial tuberosities, and the second one is the influence of the hamstring muscle. The third one is amazing gravity. Okay, what happens when there is a gravity acting on us? Okay, especially to the pelvic. Okay, gravity pushes the pelvic down into the seat. Once the gravity pushes down the pelvic what the pelvic will do, pelvic seeks for a support. The only support available for the pelvic is the backward in the wheelchair. So what does the pelvic is? It's rotate backwards, okay, and it takes rest over there. And if you look at any person sitting in a wheelchair, okay, the pelvic is tilted backward, and the freedom of movement, what I have in the wheelchair or in the chair wherever I'm sitting, is only possible is forward movement. Okay, that is the reason why when the patient is sitting on a wheelchair, or when we sit on a wheelchair, we always complain that patient is sliding from the seat, sliding from the wheelchair. This is a huge major complaint. The patient slide from the wheelchair because of the gravity. Because of gravity, the pelvic goes tilted backward, and then the only movements available is in the wheelchair is forward. So I'll move forward, then I slide from the cushion, I slide from the wheelchair, whatever it is, then the whole posture goes into asymmetry. All right. Okay. Conclusion on what happens when we sit. We normally change our posture continuously. It is a continuous posture. Okay, this happens unconsciously most of the time. Yes or no? The answer is yes. We don't say, okay, now 5 minutes over, right leg over the left leg. Okay, 10 minutes over, now left leg over the right leg. Okay, put your left hand over your cheek, right hand over the cheek, cross your hands. Okay, change your position. It never happened. It happens unconsciously most of the time. Okay. Imagine a wheelchair user. Imagine a patient who is sitting in a wheelchair over the period of time. For example, if the patient is sitting in a wheelchair for more than 10 hours in a day, okay, if he has having an poor weight shifting skills, okay, it's a real challenge for them. Those who are having a disability or inability to change their weight shift. Okay. So the key is the pelvic. In sitting, the pelvic is the key. If pelvic goes wrong, everything goes wrong. If pelvic becomes right, everything becomes right. Okay. So in conclusion, pelvic was the key in sitting. So if you take care of the pelvic, okay, rest of it will be taken care. If you don't take care of the pelvic, everything will go wrong. All right. So far it's clear. Any doubts? Anything have in the chat box, Mrs.
No
Reema?
doubts, sir, no doubts.
All right. Thank you. Now, let's go to the most important concept in sitting and mobility, as far as my concern is the symmetrical posture. I end of this webinar, maybe you remember few and you don't remember many things. Okay, it's fine. But if you remember these principles of symmetrical posture, I would really appreciate all of you. So pay attention to it. Okay, the symmetrical posture. All right. Once you know what is symmetrical posture, it is easy to know what is asymmetrical posture. Our body is made up of a lot of segments like head and neck, the shoulders, the trunk, the pelvic, and the thigh, knees, lower legs, and ankle. Each segment has got its own symmetry. Just now in the previous slides, we have seen that the pelvic is the key. So let's begin with the pelvic. What is the symmetry for the pelvic? If you say what is symmetry for the pelvic has to be slightly anterior and no rotation or no elevation of either side. So this is the symmetry for the pelvic. Now comes the spine. The spine has to be straight in coronal plane, which is you have to maintain normal anatomical curvature of the spine, which is mild cervical lordosis, mild thoracic kyphosis, and mild lumbar lordosis. So this is the symmetry for the spine. Now, symmetry for the thighs and legs. Okay, meaning the thighs and legs has to be slightly separated, slightly abducted, and slightly externally rotated. And it has to align with our upper body. So this is the symmetry for the thighs and legs. Then hip, the knee, and the ankle are flexed to 90 degree. This 90 degree hip flexion, knee flexion, and ankle flexion, it's a reference range only. Okay. And the head has to be in upright and midline. Okay, no flexion, no extension, no side flexion. It has to be aligned, upright, and it has to be in the midline. The shoulders can be relaxed without elevation or without depression. And arms can be supported. Here comes the picture for the symmetry. Okay, if you look at the pelvic is aligned symmetrically, the spine is aligned symmetrically, and which is 90, 90, 90 posture. The hip flexion is 90, knee flexion is 90, ankle flexion is 90, the head is in the midline, the arms can be supported. Okay, so this is the exact picture for the symmetrical posture. Okay, is there any doubts in this? Because this is, as I said, this is the important concept to understand the seating and mobility. This is very base. I think it's clear, so I think I can move to the next slides.
Yes, sir.
All right. Anatomical reference points. Once you know symmetry, now it is easy to know what is asymmetry. All right. Now, anatomical references points is if you want to practice in seating and mobility, if you want to do a proper assessment, you're supposed to evaluate properly the pelvic. If you don't evaluate the pelvic properly, your assessment might go wrong. Okay, your findings, your postural analysis might go wrong. So for that, you're supposed to have a skills to evaluate the pelvic. For that, you're supposed to know, okay, how to palpate the pelvic. Okay. Now I will show you 5 anatomical reference points. Okay, you can give me your answers in the chat box, please, as early as possible. What is this? The parts of the pelvic. Answers. The chat box.
Iliac crust aces.
Okay, thank you, iliac crust. Thank you so much. And what about this bony prominence in pelvic?
Anterior superior iliac spine.
Yes, anterior superior iliac spine. Thank you. And this is, if you say anterior, and the answer is B has to be posterior superior iliac spine. Thank you. And what about this, which is in the femur bone?
Greater trochanter.
Greater trochanter, thank you. And this is ischial tuberosities. Thank you
Ischial
so much.
tuberosity.
Thank you. We have 5 important anatomical reference points. Okay, if you know how to palpate these things, okay, almost all your postural analysis assessment will be proper. So you're supposed to know how to palpate iliacus, you're supposed to know how to palpate ASIS and PSIS and GT and ischial tuberosities. All right. So keeping in this mind, now we move on to the asymmetry of the pelvic. We have just seen what is symmetry of the pelvic. We said the pelvic has to be in slightly anterior and with no rotation, with no obliquity. Now we will see what is the asymmetry of the pelvic. Asymmetry of the pelvic, you know what are all there. There are posterior pelvic tilt, there are anterior pelvic tilt, there are pelvic obliquity, and there are pelvic rotation. There are 4 asymmetry of the pelvics. Okay, now let's see what is anterior pelvic tilt. Okay, anterior pelvic tilt, what happened here in this picture is the ASIS of the pelvic is in front of GT, which is greater trochanter. So if the ASIS moves forward of GT, it is called anterior pelvic tilt. If here in the second picture, if you see here, the ASIS is behind of GT, it's called posterior pelvic tilt. And here, the first picture is pelvic rotation. Okay, what it means is if the ASIS is forward and one ASIS is backward, this is called pelvic obliquity. And sorry, it is rotation. The pelvic obliquity is one ASIS will be higher and one ASIS will be lower. That is called pelvic obliquity. I'll repeat it again. In anterior pelvic tilt, the ASIS will be in front of GT. In posterior pelvic tilt, the ASIS will be back of GT. In pelvic rotation, one ASIS will be forward of another. In pelvic rotation, sorry, and in pelvic obliquity, one ASIS will be higher than the other. All right, this is the 4 asymmetry of the pelvic. Now, what is the asymmetry of the spine? We all know as a professionals, there is a scoliosis. What is scoliosis? Which is lateral curvature of the spine. And what is kyphosis? It's a posterior curvature of the spine. We sometimes have a kyphoscoliosis together, and lordosis is an anterior curvature of the spine, or excessive anterior curvature of the spine. All right. We have seen the symmetrical posture slides just before, few minutes. And what are all the benefits of proper symmetrical posture? So if I make the patient sit in symmetrical posture, what the patients will achieve? Okay. The most important benefit is we prevent the deformities of the pelvic and the spine and other orthopedic problems. Example, we have a tightness, contracture, subluxation, dislocation, and everything. Okay. All right. When you make the patient sit in a symmetrical posture, he interact between the environment is much better way than when he's sitting with an asymmetrical posture. Symmetrical posture, it relieves the pressure. For example, if you sit with the pelvic obliquity, if you sit with the posterior pelvic tilt, what happens is one side of the pelvic gets more pressure than the other side. So if you make the patient sit in symmetrical posture, okay, you can equally distribute the pressure. And the symmetrical posture itself, it regulates the tone, whether it is flexor tone dominant or extensor tone dominant, doesn't matter. And it improves the functions of the upper limbs. It improves the respiratory function. Imagine you have a scoliosis, and if you have a scoliosis, what happens to the intercostal muscles? Intercostal muscles are not functioning properly. You will have respiratory problems. So once you make the patient sit in symmetrical posture, we discussed just before, then the respiration functions can be improved, and improves intestinal functions because you are making the patient upright against gravity, so that can improve the digestion as well, and it prevents back and shoulder pain. Finally, it helps the individual to achieve their ADL skills. So this is the benefits of proper symmetrical posture. Now, let's move on to the common diagnosis, what we are dealing with in seating and mobility clinic in PMR hospital. This is the most common diagnosis we are dealing with in seating and mobility clinic. Most common is CP and developmental delay. We have spina bifida, muscular dystrophy, Down syndrome, neurodegenerative disorders, and SMAs, TBI, spinal cord stroke, MS, poliomyelitis, orthopedic problems, amputation, and others. Others category, there are many patients are now falling in this category. For example, like renal disease, heart problems, OA, and low back pain, cervical spondylosis. All those things comes under others category as well. So we deal with most common diagnosis is is mostly CP, and if you take adult patients, we are dealing with spinal cord injury, MS, and all those things, all those diagnoses. All right. Now, let's go to understand the wheelchair components. This is also one of the important topic when you want to understand further more about seating. I said the first one is symmetrical posture. Now, the wheelchair components. Wheelchair is divided into two major components. One is mobility base, the second one is seating system. If you know in detail about what is mobility base, and if you know what the details about what is seating system, you can recommend a proper seating system to the patient. So for that, you're supposed to know what is the mobility base and what is the seating system. All right. As I said, there is two major wheelchair components. Okay. What is under mobility base? First, okay, types of wheelchairs. I will explain to you types of wheelchair. We will discuss more in detail coming later slides. And the mobility base, after the types of wheelchair, we have a tilt-in space and recline option. You know the difference between tilt-in space and recline option. Tilt-in space, the hip angle remains the same. For example, let's say the hip angle is 90 degree. In tilt-in space mechanism, the hip angle remains the same at 90 degree. But whereas in recline, the hip angle changes. From 90, it can go to 100, 110, 120, 130, whatever it is. So tilt-in space, the hip angle remains the same, and recline, hip angle changes. Then comes the rear wheels. You can see the picture here. The wheelchair, the rear wheels, we have different types of rear wheels, and the caster is a smaller wheel in front, and we have an axle plate where the rear wheel is getting attached with the rear wheelchair, and we have armrest, and we have an hangers, and we have a footrest here down, and we have a push handle and anti-tippers just behind the wheelchairs for the safety, and other accessories like oxygen concentrator, ventilator tray, suction machine holder, feeding hook, cane holder. All these options are coming under mobility base. Okay, when you're going to recommend any types of wheelchair, okay, first the name of the wheelchair comes, and the remaining things, everything you have to be specific what you want for that particular patient. So for that, you're supposed to have a knowledge about what is mobility base is all about. Now, let's go to seating system. What is seating system? Seating system, which means exclude the mobility base, the remaining all comes under the seating system. So what is remaining is the cushion, the backrest, and the head support, lateral thoracic support, abductors, adductors, and then shoulder belt, hip belt, ankle belts, and other accessories like a tray, bag, etc. All right, this is about seating system. Now, let's go into detail of these things, mobility base and seating system one by one. Let's go to the types of cushion. First, let's finish the seating system, then we'll go to mobility base. Types of cushions available. The first basic types of cushion is sling cushion, then foam cushion, then memory foam cushion, then gel cushion, then foam and gel cushion, then honey shell cushion, then air cushion. These are all the basic type of cushion. There are millions of cushions available in the market. Okay, based on the foam cushion, based on memory foam cushion, gel cushion. If you search in the types of internet, there are lots and lots of cushions. You will get it. But you're supposed to understand what is the basic types of cushions. From there, you can recommend which cushions will be suitable for the patient. Now, what is the benefits of the cushion? What is the role of the cushion? Okay. The main role of the cushion, it provides comfort. Look at the picture here. How beautifully this pelvic is seated on the cushion. And look at the trochanter's here. Okay, how beautifully taken care, these two. The trochanter's and the pelvic, which is, I'm talking about femur and the pelvic. Look at the cushion here. It is contour shape. It is not flat. It is not straight. When you have a cushion, contour cushion, okay, the pelvic, the ischial tuberosities, which I'm talking about, it is really positioned properly, and the lateral trochanters are taken care properly, so that it gives lateral stability and the pressure distribution, everything perfectly. This picture. So the role of a cushion, it provides comfort. When you position like this, when I give a cushion like this for you, you feel more comfortable. You will not change your positions quite often. The second six, it helps in improving the posture. Yes, definitely, because the pelvic goes perfect, then everything comes perfect. Pressure relief. So main role of cushion is relieve the pressure. The equal distribution of pressure is possible if you position the pelvic in symmetrical posture. It provides stability, as I was talking about lateral stability, and the proper cushion can always provide forward stability as well. And finally, it absorbs the shock when the patient is moved on uneven surfaces or uneven terrain, whatever it is. So this is the main role of a cushion. I'm going to share you some video about the cushions. Okay, so now on we will have more videos to come. So let me share here the cushion first. Okay, is it coming, the cushion? Are you getting the videos, Ms. Rima?
Sir.
All
Yes.
right, thank you. All right, so I will just give an intro before I start about the cushion. You can see here in this video, there are number of cushions are available. Okay, as I said, starting from foam cushion, memory foam cushion, gel cushion, and memory foam with gel cushion, air cushion, honeycomb cushion, everything I have shown you a model. All right, now I open the cover. One minute, let me. All right. Look here, this is the example of foam cushion. This is the basic foam cushion. Okay, next one is going to show you a memory foam cushion. Just have a look at it, the shape and the texture of the cushion. Of course, you cannot see it, but I mean, you cannot feel it, but you can just see the structure and the design. See how beautifully molded, and see the contour shape, which just I showed you the picture, how the pelvic was seated on the contour shape. And this is a memory foam cushion. When I say memory foam cushion, it takes the shape of the pelvic when you sit. Okay. This is for adult memory foam cushion. Now I'm sharing you the pediatrics memory foam cushion for the children. Okay, again, it is beautifully contoured. Now this is a gel cushion. This is a solid base, and you can remove the gel pad. Okay, this is one of the cushion for those the children, those who have an skin integrity issues. And this is again the gel cushion for your information. This is for adult gel cushion. This is solid base. You can remove the gel layer. Yeah, he's doing that. And look at the base. It's beautifully contoured. When you have a contour, the pelvic will sit very nicely and in the symmetrical posture. And here comes memory foam with gel cushion. Look here, he is going to remove the gel pad now. So each type of cushions, it has got its clinical values. Okay, you cannot recommend for everyone gel cushion, everyone gel with foam cushion. You know, proper assessment is needed, and these type of memory foam with gel cushions will really suit for the patient, those who are at risk of skin breakdown. And look at air cushions. this is a little expensive questions, and this is those who are really in high risk of skin breakdown. We recommend these are questions, especially for the spinal cord injury patients, those who were lost their sensation because of the impact. And you can see this is a multi-layer foam. On top of that, you have a gel layer. Okay, these cushions can be benefited for the people, those who are really at risk of skin breakdown and they have a poor cognition, the weight shifting skills are not going to happen. So for them, if they're sitting more than 7 hours, 8 hours in a day, so these cushions will really help them to take care of the pressure, and it provides the comfort, everything. All right. So look here how he is sitting on the cushion now. It's a memory foam cushion. We have seen one picture. Let's look how the pelvic is positioned on the contour, and look at the here. Look at the lower leg length and lower leg. 1 minute. The position of the lower leg. You can see how it is slightly abducted, slightly separated. Okay, you have all this is happening when you have a proper cushion. Thank you. Now let's move on to the slide. If you have any queries, please post your questions in the chat box, please. Now, let's go to type of backrest. We have seen the cushions. Now we'll go to types of backrest. Okay. So as like a cushion, we have a types of backrest also. There is a sling backrest, there is a tension strapping system backrest, there is a solid backrest, and there is a foam in place backrest. Okay, you can see the different series of backrest. It's with the different comes with a different contour shape. Okay. Now let's go to the backrest videos. I have a small video for you about the backrest. Okay. There is a foam in place backrest, and you can see the variety of backrest. It comes with the different contour shapes. This is, I have only few model activities to show you. And look at here. This is an active wheelchair user backrest. Okay. And look at the mold, how beautifully it is contoured to have the more contact area of the spine. This is for pediatrics solid backrest. Okay, it's always showing the shape of the contour. Okay, when you have a more contour, you have a more contact area, more footprints. Okay, when you are sitting, if you want to have a more stability and comfort, you're supposed to have a more contact areas. Look at the shell now. The shell is beautifully contoured, and on top of that, you have an memory foam. And this is very lightweight, solid contour backrest, and I think it is around 600 grams. I think you can lift it in one finger. This is for the active wheelchair users. And now is going for this is called comfort backrest. It is full of, it doesn't have a shell actually speaking, but it is having a memory foam and with the contoured shape. Yeah, he's trying to open it and look at the shape of this contour backrest. Yeah, it's nicely molded. When you sit against this backrest, you feel more comfortable. You will not change your position. The spine will remain the same. It will be a beautiful experience. And this one looks how deep this contour is. Okay, this is more than 6 inches of deep contour backrest. There are people, those who needs more support in the spine, we can go for deep contour backrest. And this one is, I'll just explain to you. This is a mold, foam in place mold, we say. Okay, when you have a fixed scoliosis and kyphosis, okay, the spine is not correctable. Okay, then you're supposed to take a mold of the spine. Okay, this is just a model. Okay, how we took the mold of the spine. Okay, this is back. He's showing, and that's it. for the backrest. Now we will move on to backrest. Okay, we have seen cushion, we have seen backrest. Now we'll come to the mobility-based accessories. We see now some of the pictures which shows you for the rear wheels. Look at the models and designs, because some of the people, they like this look, aesthetic look. And here comes the casters. Okay, different types of casters and different types of armrest, different types of hangers. You see 90-degree hangers, 80-degree hangers, 70-degree hangers. Okay, and then elevating hangers. You have fixed hangers here. Each type of hangers, it makes significant role in it. So we cannot just write 70-degree hangers for a patient. You cannot just write 60-degree hangers. You cannot just write elevating hangers. You're supposed to have a clinical reasoning for each specifications what you are recommending. Now we have different types of head supports. We have different types of belts. You can see the hip belt here, and shoulder harness here, and then ankle luggers here. Okay, now I'll show you the accessories videos. Okay, now you can see different types of head support you have seen in the picture. See the contour shapes are different, and look at the design. Look at the tech, the materials is different. And here comes the abductors, adductors, and this is foot box, and this is ankle luggers, and this is shoe holder, and this is lateral pad. I'm talking about now the seating system. This is shoulder harness, different types of shoulder harness, different types of hip belts, lap trays, different types of lap trays. This is padded lap tray. Okay, all this, we have seen this video accessories, it comes under seating system.
Sir, there is a doubt asked by someone.
Yes, please.
What is the reason for different hangers?
Different hangers. Okay, keep this question later when you have in the question and answer sessions. Maybe I can answer this question, please.
Okay, sure.
Okay, thank you. Okay, I have one question that I will tell you later. Now let's go to the types of wheelchair. The most interesting topic now we are going to discuss is types of wheelchairs. We have seen what is the mobility base. We have seen what is seating system. In the mobility base, the first one, it came the type of wheelchairs. Okay, we have different types of wheelchairs. Okay, as Dr. Madam Bijlani said, we have different types of wheelchairs. We read in the book and we have never seen it. Now I have the opportunity to show you the different types of wheelchairs. All right. We classified in three categories in our PMR and seating and mobility clinic. We can classify the types of wheelchair: independent wheelchairs, dependent wheelchairs, and transportation wheelchairs. We will see what are all the independent wheelchairs. The first one is semi-active wheelchairs, active wheelchairs, foldable, active wheelchairs, rigid, ultra lightweight wheelchair, power assist wheelchair, power wheelchair, bariatric heavy-duty power wheelchair, and full option power wheelchair. This is how we classify wheelchairs, independent wheelchair in our department. We go to dependent wheelchair category. We have a stroller, and we have a dependent wheelchair with tilt-in space mechanism or recline mechanism. I told you what is tilt-in space and recline mechanism in the mobility base. And we have a comfort wheelchair under the dependent wheelchair category, and we have a rapid standard wheelchair and bariatric heavy-duty wheelchair. I will show you the pictures and videos in my upcoming slides. What is independent wheelchair, what is dependent wheelchair, and everything. And we have a transportation wheelchair as well. This is called standard wheelchair. All right, so three categories wheelchairs we have seen. Now, we will just see the picture, how the semi-active, which is under the independent wheelchair category, how it looks like, semi-active wheelchair. Okay, the semi-active wheelchair looks like this. This is not the picture is taken, it is taken from Google, but this is an actual chair we are dealing with in seating and mobility clinic. the picture which I'm showing to you now, it's going to show you in the upcoming slides all the chairs which you are using in our clinics. Active wheelchair foldable. When you say foldable option active wheelchair, you can see there is an X bar in the mobility base down, which means when the chair has an X bar, okay, which means the chair is foldable. When the chair does not have X bar, which means it is not foldable. It is as simple as that. Active wheelchair rigid, as I said, see here, there is no X bar. Okay, it is a straight bar here, which means the chair is not foldable. Only the back is foldable. It's called back, fold down back. So we have seen active wheelchair foldable, and we have active wheelchair rigid. We have an ultra lightweight wheelchair. Okay, look at ultra lightweight wheelchair again. If you look at down this bar, which is straight, which is not X bar. Okay, the difference between active rigid and ultra lightweight wheelchair is the weight. The name itself, it's called ultra lightweight. Okay, we have given the criteria that anything which is 8 kg and below with the rear wheel, it comes under the category of ultra lightweight. Anything it is above 8 kg to 13 kg, it comes under active wheelchair category. All right. So this is very lightweight. As I said, this is 8 kg from 8 kg to down. Okay, with rear wheels, without accessories. Now we have a power assist wheelchair. This is how the power assist wheelchair looks like. There is a motor on the rear wheels either side. All right. And power wheelchair, if you see, there is a motor and there is a joystick also there. Okay, this is a power wheelchair model, and there is a battery down under the cushion. And bariatric power wheelchair, if you look at here, there is a joystick and there is a battery down. What is bariatric meaning? Okay, if the seat width goes more than 20 inch, we are always dealing in inches, not centimeter in our clinic. So any width goes more than 20 inch, it is called bariatric wheelchair. So bariatric meaning it can be 20, 21, 22, 23, 24, it goes till 26 inches width. So this is the model of the bariatric power wheelchair and full option power wheelchair. This is a model of full option power wheelchair. This is a full option power wheelchair, which means that the single joystick control, the patient can control everything. For example, the chair can be tilted. It is called power tilt, and it can power recline, power elevating hangers, and it can lift the chair. Okay, so it has got 4 options: power tilt, power recline, power elevating, power lift. Along with that, he can drive the chair as well. I have a beautiful video for demonstration so that you will understand in the upcoming slides. It is called full option power wheelchair. Now let's go to the dependent category. Dependent category, as I said, this begins with the stroller. This is the stroller we are dealing with. It's called Hoggy. If you say stroller, it is mainly for children, pediatrics population. Approximately, I can say age starting from 2 years till 10 years. We are recommending stroller for these children. Okay. So you can see the mobility base and seating components. What are all we see? The accessories, head support here, and laterals are here, and everything. I have a video so that you will have a better understanding about stroller. Type different wheelchair, as I said, different wheelchair. It can be tilt in space and with the recline. Okay, with all the accessories mounted on it. So this is the picture for the comfort wheelchair. Comfort wheelchair also has a recline and a tilt in space. The only difference between comfort wheelchair and dependent wheelchair is the comfort wheelchair cannot be foldable, but the dependent wheelchair, it is foldable. So if you say cannot foldable, which means accessibility is going to be real issues. If you have a good accessible car and accessible transportation, we can recommend this for the patient. Now, adaptive or customized standard wheelchair. This is an example for adaptive standard wheelchair. You can see all the accessories are mounted on the mobility base and standard wheelchair. This is the example for standard wheelchair. All right. Now, are you ready for the types of wheelchair video now? I will just show you before that small video of all the wheelchairs. All the wheelchairs you have seen, we have displayed for you. Active wheelchair, dependent wheelchair, stroller, ultra lightweight wheelchair, full option wheelchair, power wheelchair. All the wheelchairs we displayed for your reference here. Active folding, active rigid. Now, let's start from independent wheelchair. Independent wheelchair, first the wheelchair types we said semi-active. Am I right? Yes. So this is the model of the semi-active wheelchair, this is what we showed in the picture. That is the pediatrics, and this is for adult. It can be for the teenage also. Okay. Look how it looks like. Okay, the rear wheels and the hangers. First, look at the mobility base, types of armrest and the back post, the caster, everything. And he is going to remove the seating system alone now. Seating system, you see cushion, the backrest, lateral support, abductors, everything. So this is the mobility base. When I say the seating, the wheelchair is divided into two major components, mobility base and seating system. Now, what you have now seeing here, this is the complete mobility base. The rear wheel, casters, hangers, the push handles, and you have the armrest and everything here. And you see how he's folding this chair. How we mount the seating system on the mobility base. We can remove the armrest. Okay, I'm sorry for this, something happened. I'll show you the other video, how to fold this chair. Let's go to the second one is active folding. This is the example of active folding. And I will tell you this person is Mr. Mohammed. Okay, he is closely working with me in my seating and mobility clinic, and we are traveling together more than 10 years. He is very close to me, and I don't know whether he's attending this webinar or not. If he's attending, I'll say hi to him. Okay, I don't know, because he's traveling next week. Otherwise, he would have attended with me. I would have also included him. I don't know whether he is there or not. Mohammed, if you're there, please just raise your hand. Otherwise, it's fine. I'll proceed this presentation. This room is our seating clinic. Now, this is actually, I said, active wheelchair foldable option. If you look here down, there is an X bar now. Okay, when you have an X bar, this wheelchair is for foldable. See? And he is removing the hangers. This is 80-degree hangers. He is removing the rear wheels. This is an axle plate. So this is how you fold the chair. And the same way, you can bring it back. You can fold and unfold. Everything is easy. Now let's see what is the next one in a independent wheelchair is. Let's go to the ultra lightweight wheelchair. As I said, ultra lightweight wheelchair and active rigid wheelchair are almost all the same. If you look at here down, the bar, it is not X bar, this is straight bar. Okay. I said ultra lightweight wheelchair or less than 8 kilograms in weight. It's very lightweight. Only way you fold this chair is fold on back. It will not fold like an X folding. And see, this is less than 4 or 5 kilo. You can lift it in by one hand. This is ultra lightweight wheelchair. And let's go to the power assist wheelchair. Okay, before that, I'll go to active wheelchair pediatrics. I did not show you the pediatrics. This is the pediatrics active wheelchair. And this does not have much of accessories. The difference between semi-active and active wheelchair is semi-active wheelchair, you will have more accessories in the seating system. But in active wheelchair, you will not have that much of accessories in the seating system. Okay, let's go to the power assist wheelchair now. Look here, I don't know whether you will have option to see this again in your practice. So when you have a power assist wheelchair, I'll again go from the beginning. This is the motor here. Okay, it is attached with the wheelchair within special axis. Okay. and this is a rigid wheelchair. I'll show you one more video how we fold this power assist wheelchair. We have seen folding same way. There is not much difference. When you say that this is a power wheelchair, is it going to be difficult? No, it's not going to be difficult. You can see very easily. Just press this button and it will come out. But is it going to be a little heavy because the motor? Maybe I can say that the one wheel it will weigh around 10 kilograms. So two wheels it will be 20 kilograms, and the wheelchair weight may be around 7 to 8 kilograms. Totally it will have around 25 to 30 kilogram of weight. Okay, so this is very compact folding. You can put it in the bag and you can travel. All right, now we'll go to the power wheelchair. Now you can see the other power wheelchair. This is for pediatrics power wheelchair. We have a 3 power wheelchairs. This is for pediatrics population, foldable criteria, and this is also for pediatrics. And this chair will have a tilt in space option, power wheelchair with tilt in space option. This is dynamic tilt in space. And this is also power wheelchair with dynamic recline. There is a difference. I said in tilt in space the hip angle doesn't change, but in recline the hip angle changes. I think almost all I finished for the independent wheelchairs. Okay, I have a dependent wheelchair now. Yes. Okay, this is from dependent wheelchair category. Dependent wheelchair, when you say there will be a lot of accessories in it because the patient is dependent in wheelchair mobility. Okay, you can see the rear wheel, it's a small rear wheel, the casters, and the seating system. You see all the accessories are there: head support, laterals, and the hip belt, shoulder harness, everything. And this wheelchair now is going to show you how to tilt in space. Yeah, this is tilt in space. The hip angle doesn't change, and the recline hip angle changes. So the same way how we did for semi-active wheelchair, we have to remove the seating system and everything. So I don't want to take your time again to demonstrate these things. Okay, then we go for comfort wheelchair. This is the example of comfort wheelchair. I said this is not foldable, so accessibility is going to be a real concern. But this is very good chair for those who are having bedridden, those who are bedridden, and those who are in palliative care. Okay, this wheelchair it's a good option wheelchair. So it just got both dynamic recline as well as dynamic tilt in space option. See both together possible, and along with this they have an elevating hangers also. All right. You can see the elevating angles. You can come to bring it to 180 degree. All right. All right. Now I think almost all we're finished. This is the full option power wheelchair. Just to have a look at it. As I said, power tilt, power recline, power elevating, and power lift options. I'll show you the demo. Okay, this is how it looks like. All right, now I think almost all I showed you the demo of types of wheelchairs. Now let's go to the assessment. Okay, is it everything goes fine so far? participants?
Yes, sir.
Okay, Ms. Rima, can I know how much time I'm remaining? I'm sorry. Once I start, I don't know.
27, sir.
Yes. So, how long I can go furthermore?
The webinar time was given as 1 p.m., sir, but
Until 1. Okay, all right. All right, thank you. Okay, now let's go to the seating assessment. Okay, seating assessment, it involves the following steps. It starts with an interview, and it goes to an observation, and it goes to supine evaluation. Then it goes sitting evaluation. Both supine and sitting evaluation, we call it mat evaluation. And then finally, it is for measurements. All right. In seating assessment, in physical examination, I mean, in the mat evaluation, what we do, we assess pelvic and spine. As I mentioned in my previous slides, okay, the anatomical reference points, okay, if you all aware about that, we assess the anatomical reference point, the pelvic, and then we assess spine. Okay, how is the pelvic? How is the spine? Is the pelvic in neutral pelvic or anterior or posterior or oblique or rotation or everything? And we assess the spine, is there is scoliosis, kyphosis, because we said pelvic is the key. So the first evaluation has to be on the pelvic. Then we assess the head and neck, upper limb functions, lower limbs, muscle tone, muscle power, sitting balance, endurance, skin conditions, and then deformities of the pelvic. Is it flexible, partially flexible, or fixed? Then we assess cognitive abilities, we assess ADL skills, we assess accessibility skills, and finally we take measurements. I have videos, also demo videos I will show you. This is how we assess in supine evaluation, which is a mat evaluation, and this is sitting evaluation, and finally we'll take a measurements. Okay, this is in brief, but it is not like this. This is very comprehensive assessment what we are doing it. Okay, now I have a case scenario video 1. Okay, let's all watch about how the session starts. Okay, I'll give you general information about this this patient. He's 24-year-old male. Is diagnosed with CP diplegia. He underwent bilateral hamstring release in 2013. This is an idea. You know, as I said in my first class, in the beginning slides, hamstring plays a major role. So already he went for release, which means that he is having a tight hamstrings. And furthermore, he is independent in his ADL skills. He is having good cognition and communication skills. Okay. All right. This is our session started actually. Now he is coming in for an assessment. He's a CP diplegia. As I said, look at the posture, how he is on the wheelchair. Just observe his pelvic, observe his spine, observe his lower limbs, observe his knee flexion, observe everything. Now he's going on interview process. I cannot show you the whole interview process because of the time limits. Okay. We have a well-defined assessment form. He's just filling about all the interviews. Okay, he's asking about his hamstring release. Okay, he's documenting it. From there, he goes to, in the seating process, we said assessment, interview, observation, then goes to supine evaluation now. See how he transfer himself. You can see all his activity participation, how independent he is in transfer skills. And just look at this chair, what he is using. Okay, always observe the present equipment. What is this? This is an active wheelchair. It's coming in an independent wheelchair category or dependent wheelchair category. This is independent wheelchair category. Yes. And this is an active wheelchair. Is it foldable or rigid? This is actually rigid wheelchair. Okay. You have to always know about the present equipment. And he is doing all his ADL by himself. You can see how he's independently performing his skills. Okay. The therapist is going to do a supine evaluation. And he is one of my colleagues, actually, is working close with me. His name is Mr. Harris. As I said, it's in the evaluation first, we used to go and check the pelvic. The pelvic is the key. It's checking the spine. It's checking the scoliosis and kyphosis. It's trying to palpate the ASIS. Now he's checking his hip flexion. I said that if you want to sit, okay, the hip has to be flexed. Optimal range is 90 degree. Okay, we are checking how much of the hip flexion is getting now. In supine. Imagine in supine there is no gravity acting on him, but in sitting, the gravity will take. Okay, almost all is reaching to 90 degree, but it's not easy. It looks like the people are struggling over there. We are assessing with the goniometry. All right, and the next is they are assessing the popliteal angle, which is the hamstring tightness, how much the tight this hamstring is. Suppose we supposed to get the full range of knee extension, at least 170 degree, but if look at the range. I don't think he's getting 170. Yeah, he's saying yes, fine. He's feeling pain. Maybe I feel that 30 degree shortage of hamstring. Okay, is everything they are documenting now. We're checking the knee flexion now. We're supposed to have a hip 90 degree, knee 90 degree to make them in a proper sitting position. They're checking his ankle. All right. Now let's go to the sitting evaluation. Okay. We made him sit now. Again, the key is the pelvic. We are palpating the ASIS now. They're assessing whether it is anterior tilt or posterior tilt or neutral pelvic. Okay, now let's go to the spine. How is he sitting? Is he maintaining normal anatomical curvature of the spine? How about the lumbar lordosis? No. Okay, is there any kyphosis, scoliosis? And how about lower leg? Now you're supposed to know what is symmetrical posture. If you know symmetrical posture, it is easy to know what is asymmetrical posture. Look at his knee flexion. He is unable to keep the knee at 90 degree all the time because of hamstring. All right. So we have seen the video of okay, scenario now. Okay, right. So we've seen this. Okay, what is the outcome of this assessment? The postural analysis. I will just give you feedback about it. Okay, this is his postural analysis of the 24-year-old male CP diplegia. His posterior was tilted. His pelvic was tilted posteriorly, and he is having kyphotic spine, which is flexible, and he is having functional upper limbs. His lower limbs are adducted and internally rotated, and he is having a hypertone. Lower limbs are more than upper limbs, and he is having bilateral hamstring, rudder, and TA tightness. So this is our postural analysis from the assessment. So he is sitting in an asymmetrical posture. We have seen in the previous slide what is symmetrical posture, which means now he is totally sitting in asymmetrical posture. Okay. Next slide. Okay. Now we know the type of wheelchairs. Yes, we have seen the types of wheelchair. Okay. Now can I have some answers, please, from the participants? Okay. I have given the case scenario about him and the general information and postural analysis. Okay. So now we are going to choose a type of wheelchair for him now. Okay. Let's exercise now. Is he going to be independent or independent in wheelchair mobility? Can I have a few answers quickly?
Independent mode.
Independent. Thank you so much. Yes, he is going to be independent. If you say independent, we have a types of wheelchair 1, 2, 3: semi-active, active folding, active rigid, ultralight, power assistant, power wheelchair. We have 6 types of wheelchair. Now, which one we are going to choose for him? Any answers? If you give an answer, you have to justify.
Active fold.
Active folding. Okay, I will give you information. he is already having an active rigid wheelchair. Okay, I told you in my presentation. I believe that. Okay, he's already having an active rigid wheelchair, so he come for an assessment. So we have to now recommend a proper wheelchair. So now my answer is we recommend an ultra lightweight wheelchair for him. Why? This is my justification here. He's having good cognitive functions, he's having functional upper limbs, and the more important thing is he's already propelling his current active rigid wheelchair. So from there, I have to move on. Okay, is it clear?
Sir, yes.
Yes, okay, thank you. Now I have another case scenario, one pediatrics patient now. Okay, let's see that. Okay, you see, this is an Indian patient actually. Is almost a 4-year-old boy is carried by his father to my seating clinic, and he is taking multiple anti-convulsion medications. So most of the time he feels drowsy. Okay, I have finished the interview and I have observed, and without further time delay, I'll go to supine evaluation. I'm assessing the head and neck. Of course, this is me in the video, and I am assessing the spine, and immediately I'll go to the pelvic. I'm trying to palpate the ASIS, and I will check the pelvic flexibility, how flexible the pelvic is. I'm checking his lower limbs hip flexion. 90 degree is optimal, is possible. Okay, yes, he is in a pain now. He responds. And look at the popliteal angle of the hamstring. There is no hamstring tightness, actually speaking, but look at the ankle is not coming back. Ankle is having an bilateral clubfoot. The left side the same. See, he is now more than 90 degree of flexion. He is having a pain, and the full knee extension is coming. And this is his sitting postural analysis. See the way how he sits. Even when he's awake, this is the position he maintains. He's having poor sitting balance. He's having a poor head control. Okay, now I am doing a sitting evaluation. I'm analyzing his posture. He's sitting with a posterior pelvic tilt, which is ASIS behind of GT. And look at his attitude of the lower limbs. And going to the spine. You can see the spine is severely kyphotic and scoliotic as well. And going the course of the spine. Is it flexible? Yes, it looks like yes. Is the scoliosis flexible? Yes. Look at the spine now. This is just typical asymmetry of the spine. And look at the lower limbs now. Attitude of the lower limbs. It's supposed to align with the upper body. See? All right. Go back to the presentation now. The general information is 4-year-old boy is diagnosed with neurodegenerative disorder. He lives with his family. Parents are the main caregivers, and he is having a poor cognition and communication skills. He is totally independent in ADL skills, and he will be at the high risk of skin integrity issues. This is about this boy. Okay. What we can choose for him? Going to be independent or dependent?
Dependent.
Type of wheelchair? Dependent. Thank you so much. Okay, yes, dependent. Types of wheelchairs in different category. We have a stroller, dependent wheelchair, comfort, and artificial standard wheelchair. Yes, we are seeing the types of wheelchair under the different wheelchair category. And what could be the recommendations? Any answers?
Stroller.
Stroller. Thank you. Even I recommended a stroller for the boy, and my justification is he's having a poor cognitive functions and communication skills, and he's having non-functional upper limbs, and he's having a poor head control and sitting balance. So I recommend a stroller for this boy. I have fortunately I have it's a delivery session actually speaking. Okay, and I have his video of stroller. 1 minute. Here it comes. Okay, we position the boy, the same boy, in a stroller now. This is a stroller for your. See, I have positioned him, and look at his posture now, and look at his interaction between the environment now. He is almost all awake now, and I have a little bit of tilted. Look at the head control now. Look how he's going to interact with the environment, how he's going to explore his own environment. Look at his posture. Look at the accessories, the seating system and everything. And this is the delivery. So we are teaching the parents, how to take in and out of the stroller for the boy, and the technicians are available there, and they will teach him how to remove it, how to fold it, and how to unfold it, how to position him, how to put the hip belt, shoulder harness, and everything. So this is our actual delivery session. Okay, I'll just go a little fast forward because of running out of time. There's a lateral support. So the most important thing is the pelvic position. If you properly position the pelvic, the spine will follow. Otherwise, if pelvic goes wrong, everything goes wrong. So if you don't do proper positioning for him in this age, he will develop deformities in the near future. Already he's developed many deformities. The good thing is the deformities are flexible. Okay, this is how stroller is folded and unfolded. We are teaching the father, how to fold and unfold. All right, now let's go to the presentation again. Okay, I have some wheelchair training videos for your information. Okay, just be ready. It's going to be a nice session, I believe. I will show you some active wheelchair demonstration. My colleague, I already explained to I introduced him. Okay, he is an expert in wheelchair skills training. Okay, this is how we give training to the patients, those who comes to our clinic, especially those who are admitted inpatient. For example, let's say spinal cord injury patients, how we teach the wheelchair skills. All right, let's watch few videos. This is an active wheelchair foldable. Okay, initially this is how we train the patients. Okay, how to move forward, how to move backward, how to move left and right. Okay, all this orientation we used to teach them. Now, we are going to teach the real skills now for the patients. Okay, how to climb the obstacles, how to scrub climb. Okay, see the skills. This is really we teach. I'm not good at it, but my colleague Mr. Mohammed is really an expert in it. See how he's climbing up and how he's climbing down without losing his balance. This is absolutely important for the patient, those who are suffering from spinal cord injury. He will amaze you with his skills. Okay, I'll show you the next video, which is power assist demo. Switch on the power assist wheelchair. Power assist wheelchair, when you will give is when you have an upper limbs or not adequate muscle strength you have. Okay, you have only limited muscle strength and you have a low endurance. Okay, you can go for power assist wheelchair. The concept of power assist wheelchair is you no need to give more strain while propelling the chair. Just you give one gentle push, it will take you for furthermore. See how he is going to open the door. It's all skill. See how he is positioning his wheelchair to open the door. And just look at it how this wheelchair goes. Only one push and it takes you the long distance. This is my OT department in PMR. See, only one push and he's going to reach this target. right, now I have one more wheelchair demo. It is ultra lightweight wheelchair. And you see the skills of wheelchair. See, this is ultra lightweight, as I said, below 8 kg. He will dance on the wheelchair. He's having amazing skills. But we train the patients also, especially when the spinal cord is admitted in our ward. When we discharge, almost all he will learn the skills. If not up to the mark of Mr. Mohammed, at least he will know how to climb this curve. All right. Furthermore, no delays. Yes, thank you, Mohammed. Then I'll move on to the last slide, which is full option power wheelchair. Sorry, last video. Okay, just have a look at it. I don't know how many of you have the opportunity to see this full option power wheelchair. Okay, this is quite expensive, actually speaking. Okay, now let's watch. I said full option power wheelchair. If you say it is power tilt, power recline, power elevating, and power lift. And you can drive the chair as well. This is 6 wheels. You can see that's the mid-wheel drive. This is single joystick control. All the options you can control in single joystick. You can choose the mode. All right, now I think he's going to do a tilt in space already. Yeah, he's tilting the chair. So the patient can himself decide how much tilt he can. Okay. This type of full option power wheelchair, we used to recommend the patients with like a muscular dystrophy or SMA, the progressive diseases. Okay, and the patient's supposed to have a good cognitive functions for this. And now he's doing an power recline. The hip angle is now open from 90. The patient can feel a little bit relaxed and comfortable by doing these things. And this is power lift now. If you want to reach any objects, you can really do that. You can access to the restaurants, MBB, everything, everywhere if you want. You can still drive when it is lifted. I think he's trying that, if I'm not wrong. Yes, good. So you can access to the high level shelves. Yeah, good. Very nice. Oh, thank you, Mohammed. Okay, all right. So we have seen types of wheelchair videos. We have seen a few demos, and now I will show you quickly. I'll go through my assessment, our assessment in seating clinic. This is what we use our seating and mobility assessment form. I don't have a time to explain all this thing. Just have a look at it. This is a 4 pages of assessment. The first page is always we can fill by interview. Okay, and the second page is about the supine evaluation. The third page is about the measurement of hip angle and popliteal angle, knee flexion, everything. And then we go for sitting postural analysis, sitting balance tone. And finally, the last page, you have a measurements. Okay, this is our model seating assessment form. And I have this is our report. After you make an assessment, this is our template. This is a standardized template. We are using it for making a report. So first page is going to be all about the patient information. Second page is going to be the recommendation. If you look at here, the recommendation, we have mobility base. So for the particular patient, you type you type the type of wheelchair and then mobility based requirements. Seating system, what you want, and then finally measurement, you sign and you send it to the companies. I will show you one model report, how it looks like. This is one model report. Okay. The first page, as I said, all about the patient informations and postural analysis. General informations are here. And this is our postural analysis. And this is my justification. And this is my goals for the patient. And the second page is going to be the recommendations. I recommend mobility-based stroller. So under stroller, okay, what is my recommendation for the particular patient? So under seating system, what is my recommendations? Okay, and finally, with the measurements, And who did the assessment? We will sign here and we will send to the companies. Now, we almost reached the final stage of the presentation now. All right. Okay. How can we choose better seating and mobility? It's a $1 million question. Okay. How? Proper assessment is very important to recommend an appropriate devices. It involves, a lot of biomechanical properties, neurological properties, and behavioral factors. Okay. So if you do that, okay, half part is done. Okay. So it is an art, actually speaking. Choosing a better seating and mobility is an art. Okay. And we have to take care the concerns of the client and accessibilities of the client, how accessible he is, and in environment where he is going to use the wheelchair. And finally, not but not least, balance between stability and mobility. Okay, balancing between stability and mobility is very, very important. If you know how to create a balance between stability and mobility, you are almost all going to provide an appropriate wheelchair for the patient. Okay, creating balancing stability and mobility is, do you want independent wheelchair or dependent wheelchair? Okay, if you choose independent wheelchair, how can I improve his posture? Okay, if you go for dependent wheelchair, okay, is there any way of improving functions? So you always think about this, keep your options are open. Don't take decision immediately. As I said in the first point, it is an art. All right. Now, take home message. So understand basic about seating and mobility. If you understand the basics about seating and mobility, you can serve a lot of disabled populations and you can achieve their functional goals. So by end of this presentation, I hope you heard the basic knowledge about the seating and mobility. Okay, always think about from some patient's perspective. Okay, keep your options open and try to serve the disabled population. It's very huge based on the WHO statistics. And comprehensive assessment is vital to recommend an appropriate wheelchair to the client. Again, I'm going to go to the basics. Assessment, postural analysis is very, very important. And finally, the wheelchair is not a piece of equipment, rather it is a life for an individual with physical disabilities. So you are going to deal with the life of a patient. All right. So when I went to the conference, okay, I saw these wordings, these captions. It really was very impressive for me. It says that mobility is life. Let's move. We are all in pandemic situation now. We know that we are in lockdowns. Okay, we are not unable to move from one place to another place because of the lockdown and the pandemics. Imagine a patient. Okay, if he is unable to move from one place to another place because of his physical disabilities, okay, imagine his life. For us, mobility is life. Okay, but for them, so we professionals, we are going to help them to move from one place to another place, which means we are going to give them a life. I love this picture. So mobility is life. Let's move. Not only us, we have to help others to move. Okay. This is our seating team. Okay. Unfortunately, more than half of them are not in the picture because of some reason. So we are more than 16 therapists are working closely together, and this is my proud team. Okay. And unfortunately, as I said, okay, most of them are not there. Okay. Thank you for your attention. And questions now. I'm ready to answer.
Okay. Thank you so much, sir, for that wonderful presentation. I have noted down few questions, so shall we answer that?
Yes, please.
Yeah. So first question was reason for different hangers.
Okay, reason for different hangers. Okay, I'll go back to the slides. Okay, I think I showed you here. All right. Okay, as I said, in the sitting posture, when we analyze this postural analysis, okay, I said ideal sitting posture is 90, 90, 90, which means 90 degree of hip flexion, 90 degree of knee flexion. Okay, it depends on the hamstring influence. If there is no hamstring influence, okay, there is no tightness of the hamstring reaches to 170 degree when you are doing a supine evaluation, which means I can go for 60-degree hangers or 70-degree hangers or 80-degree hangers. When you have an hamstring tightness, which means you cannot go more than 90. Hangers has to be only 90-degree hangers. If it is 80-degree, for example, what will happen if there is 80-degree hangers? Your knee is extended a little bit away from 90-degree. Then you furthermore elongate the hamstring. So already the hamstring in sitting, it is under tension. If you elongate more, it will tilt the pelvic in more posterior. All right. If you don't have any hamstring issues, okay, I have a normal tone, then you can go for 80 or 70-degree hangers. Elevating hangers also is the same. Okay, the person does not have any hamstring issues at all. Okay, then we can go for elevating hangers in order to provide comfort for them. Elevating hangers can be given or recommended for the patient, those who are having an OA knees and those who are having with the problem in the ankle. Okay, sometimes they have edema. Edema is actually elevating hangers is not a solution, but still the people are recommending for elevating hangers. Okay, so the message is what I'm going to give answer is 90-degree hangers you're supposed to recommend for those who have hamstring tightness. If they have no hamstring tightness, no issues, then you can go for 80 or 70.
Okay.
Yeah, next question.
The next question is, what materials are used for ultra-weight wheelchairs?
Okay, ultra lightweight wheelchair is mostly titanium or carbon.
Thank you, sir. What makes clients to slide and how to prevent that? Various options available.
Oh, okay, it's a big question. It's a big lecture. Okay, all right. As I said, there are three factors we said why the patient is sliding. One, the ischial tuberosity. The distance between ischial tuberosity is only 12 to 14 centimeter. Number one. Number two is the influence of the hamstring. Number three is the pelvic positioning. Okay, the gravity. Okay, the pelvic is the key. If pelvic is positioned properly, okay, in the cushion, I will use the word in the cushion, not on the cushion. Can you see the picture now here? Am I audible?
Yes, sir.
Yeah. Can you see the picture here? If the pelvic and the trochanters are properly positioned and aligned in a contour cushion, okay, your 75% of the job is done. If you position the pelvic properly and then you put the hip belt on top of the ASIS, okay, and if you provide stability, then you give a proper backrest along with that, okay, you can prevent sliding. So it depends on the cushion where the pelvic is seated. And the backrest is also important. 3 contact areas has to be taken care if you want to prevent sliding. Number 1 is the pelvic. Number 2 is the femur. Number 3 is the foot. If 3 contact areas are contacting properly each other, okay, then you can prevent sliding.
Thank you, sir. Next question is, how do we measure pelvic pressure for cushion modification?
Oh, super. Very nice question. Okay. We have a technology, it is called pressure mapping system. Okay. We have the technology in terms of FSA. Okay. It gives an computerized reading. For example, you want to make the patient sit in the cushion. Before that, there is a mat. The mat will be placed over the cushion. Okay, and the reading will show you in the computer. Then you place the cushion. You place the patient on the top of the cushion, and then the computer will give you a constant reading. Okay, for example, how much pressure this patient is exerting on. We have a technology, and every cushions they have their own criterias. For example, the cushions which I showed you, many types of cushions I showed you, all are quality tested. Okay, they have published their results. Okay, how much pressure it can take, how much stability it can give, all types of cushions they have given their criteria. So if you want to give a pressure relief cushions, we have maybe 4 or 5 options. I can select from that. If you want lateral stability, I have the criteria. If you have forward stability, I have the criteria. So we have more options.
Okay, sir. Next question is, can ultra-weight wheelchair indication be influenced by body weight?
No, not at all.
Okay. So, do we have to do home evaluation for prescribing wheelchair for better accessibility?
Absolutely yes, 100% yes. But unfortunately, it is not happening in my clinic because of the load, case load what we have. But before prescribing a piece of equipment, home evaluation is absolutely necessary. But we used to have only through interview we used to ask these questions, but we do an home evaluation, but we are not doing an actual as a process in sitting. But it is absolutely essential.
Okay. Next question is, how is funding in Kuwait between national and non-national?
Oh, funding in, I did not talk about this. Okay. In Kuwait, actually speaking, the Kuwait nationalities, okay, they'll get this wheelchair for the free of cost. But for non-nationals and non-Kuwaitis, it is their own responsibilities. We have some the patients helping fund societies, and we have some other organization, NGOs, or sometimes they can seek help from other people, so they can approach it. For nationals, the government is paying the money. For non-nationals, they are funding resources for a flight through NGOs.
Okay. Okay, sir. One last question. What makes 60-degree flexion of hip undesirable position as it maintains spine and pelvic ideal position? Why is it not desirable?
Okay. Well, how long you will sit in this chair? For example, I'll go to this slide now. 60 degree of hip flexion. Okay. Okay. All right. The answer is very simple. Is that okay? In 60 degree of hip flexion, okay, nothing happens to the pelvic and the spine. This is biomechanics. Okay. When you go furthermore, the hamstring started to influence. Okay, this is the beauty of the hamstring. When the hamstring started to in the continuous tension, when the pelvic tilted backward. But how long you are going to sit in this position? For example, this gentleman, okay, where I showed the picture, for example, he is sitting with a 60 degree of reflection. How long he is going to be in this position? That's a question mark, because there is no back support as well. Maybe after 10 minutes, after 5 minutes, he will change his position. Okay, but this picture which I showed you just to understand about what happens when from standing to sitting. Okay, the spine and the pelvic, when it started to move, in which area, which the hip flexion range approximately. So until 60 degree, nothing happening. It goes more than that because of the hamstring started influencing. Then all this asymmetry happens.
Okay, sir, there are two more questions. So the pressure mapping techniques that
Yes.
mentioned, which is sensor based, since that is very
Yes.
costly, do we have some other tool for that?
Okay, your hands, therapeutic use of self. Being an OT, your hands are the best pressure mapping system. Before in my clinic, before we get a pressure mapping system, we use our hands. I used to keep my both hands under the two ischial tuberosities, and I used to measure them. Okay, so use your hands, but for that you need an experience.
Okay, so the last question I'll be reading out is that what are the categories or components we should keep in mind when doing home evaluation for wheelchair, I guess?
Okay, the most important thing is the accessibility. For example, if I recommend a piece of equipment, okay, how are they going to take in and out of their home? Starting from their car, they're getting down from the car, and how they're going to reach their home. What are all the obstructions from, okay, starting the entry, okay, and do they have an elevator? What about the width of the door, entrance? Where the patient or the family members, they're going to use the chair, living room, and all those things. We have to do a detailed home evaluation before that. Then we have to prescribe the piece of an equipment. For example, let's say we have seen a full option wheelchair here. Okay, let's see. Let's come to that point now. Okay, all right. Okay, I'm going to recommend the patient deserves this full option power wheelchair. He deserves. Okay, no doubt about that. But if he doesn't have an accessibility car, this weight is more than 140 kg, the weight of the chair itself. So even though if the patient deserves, I cannot recommend this chair because of accessibility issues. There are many factors has to be considered. So if not, it's going to be then what is my alternative? Always keep options open. Thank you.
Thank you, sir. So with that, we have come to the conclusion of the presentation. There are a lot of participants who are conveying their gratitude in the comment section, I mean chat box, sir. Also, I would like to ask if the participants would like to give any feedback regarding the session.
Hello, ma'am. I would like to give, ma'am.
Yeah, yes, ma'am.
So, hello everyone. I'm Yashwant, pursuing my bachelor's in occupational therapy in Sri Ramachandra University, Department of OT. So, firstly, I would like to express my gratitude to Dr. Gunasekharan sir for his wonderful presentation on this defined topic. And before thanking you, sir, I should thank my distinguished faculties for inviting you for this this webinar, and then for inviting you as a talented speaker to deliver this topic. So the use of your real examples were especially effective and helped our place to keep our teaching and knowledge parts in your context, sir. And this session was definitely a helpful and informative session where we'll update on this knowledge to our in our practice. So as an occupational therapy student, we should have an evidence-based practice. So with this evidence, we'll definitely use your evidence to our practice. And your presentation was definitely a fantastic, enriching, clear, and easy to follow, and definitely a precise presentation on this well-defined topic. So definitely to get an lecture from you in this well-distinguished area of expertise and research. So this is very useful for our students. So being in the upcoming month, I'm gonna go do my internship. So I will definitely incorporate all your protocols, your procedure, your assessment in my field of therapy with the available resources. So for this thing, I should definitely thank Dr. Raghuram sir, my HOD and President Convener of TNITA, and moderator Rima ma'am, and all my distinguished faculties of our department for this organizing and wonderful international webinar amidst of this pandemic. Also, I should thank Jyotika Bijnani for her kind words towards the department, student, and the college. Thank you so much. Thank you so much, everyone. Thank you so much, Gunasekharan sir, for your wonderful presentation. It is definitely useful because you used a lot of videos, because than having a straight offline conference, having this virtual conference, having all these videos, the assessments, and everything was definitely effective for us occupational therapy students as well as occupational therapists all over India. So thank you so much, sir. Thank you so much, everyone. Thank you, everyone. Thanks to my department.
Welcome, my dear. Appreciate you. All the very best for your future endeavors.
Thank you. Thank you so much, sir. Thank you, sir.
Thank you, Yashwant, for your feedback. Anyone else would like?
Good afternoon, ma'am. Can I take a chance, ma'am?
Yeah. Okay, Vijayadashini.
Good afternoon, ma'am. Good afternoon, sir. Good afternoon, everyone. I'm Vijayadashini, pursuing my final year of Bachelor of Occupational Therapy in Sri Ramachandra University. Thank you so much, sir, for this wonderful webinar session. We learned a lot of amazing things about wheelchair, posture, and all its benefits, all of its benefits, sir. So in the situation, I really most importantly, I want to thank Raghuram sir, HOD of our department. It is nothing is impossible during even this pandemic time. So it is not and virtual webinar is not just like a disadvantage. It is more like an advantage. He has given us this opportunity as a really, we can't explain this. This is really a very useful session, sir. We gained a lot of knowledge than reading a book because of seeing these videos and having more like a virtual practical class, sir. Thank you, sir. Thank you, ma'am, for this spending your precious time for us, sharing your knowledge with us. As they say, knowledge is power, but it is not just it is more powerful than knowledge is understanding, because with understanding comes the tolerance, and with tolerance we can move beyond our barriers which we are facing in our day-to-day life. You just made us to understand everything in a very easy way, so it doesn't, like, it is not an easy way to make everyone understand whatever you have been experienced in your field. It is really a big hard work, sir. Thank you for that. In this session, it is not like to say take home note, it is more like to say like take home book. This was a very informative session, sir. So thank you, sir. Have a great day. Thank you, everyone. Thank you, sir. Thank you, ma'am.
Most welcome. Most welcome. Appreciate you.